Thank you so much, and sorry we have overshooted the time a bit. We got the session a little late, so bear with us, and we'll try and make it really short. So, we are talking about refractive cataract surgery nowadays, and our patients are very interested in a spectacle-free life. So, an optimal biometry is giving us very good results when the situation is in the normal range. But what about when we have out of the ordinary situations? So, if you have eyes that are very large or very short, or patients who have, like we've covered, astigmatism, so we have to deal with these eyes very differently. First of all, we must counsel the patient that no matter what, however the accurate measurements and repeatable measurements we take, you may still land up with a slightly off mark IOL power. And this is very important so that the expectations are kept within that limit. So why does this happen? So when you have an eye which is either very long or short, so the effective lens position cannot be predicted that accurately. And secondly, the measurements may not be also very accurate. The IOL availability and labeling issues are also there. So you do note that when the IOL power is very high or very low, you do not get them at zero point 0.5 diopter range, but rather at 1 diopter. So you need to then see which particular power would suit them most. So the newer IOL formulae have really helped in these eyes, particularly because in addition to the axial length and the average K, there are a lot of other parameters that are being taken into consideration. And the most important out of them is the white to white horizontal measurement. And this plus the fact that it was understood that the previous formulae were sort of based on larger lens having a deeper AC and shorter eyes having a shorter AC depth was not exactly true in most of the cases. So, other thing that is very important when you are dealing with these eyes is that you must personalize your A constant. So, use the newer generation formulae, use better biometers like the IOL Master and the Lens Star, and input all the measurements, particularly if you've done the other eye, then take that also into consideration. And when you're measuring, for example, in the myopic eyes, you have to see that optical biometer is the way to go forward. You should be able to see the fovea. And the if you do a contact, you must avoid a contact. You could, if you do not have the optical biometer, do an immersion scan, and in that case you should try and see that you have the A and B scan together, so that you are able to see that you are at the fovea and you're not at, say, a posterior staphyloma. Always aim to be a little myopic. And in the formulae, of course, the Barrett Universal 2 is something that is doing very well in most of the extreme eyes. And you could use the Wang and Koch adjustment in the holiday when the axial length is 24.5 to 26 millimeters. And the Hill RBF method uses artificial intelligence and is recommended for IOL powers of +6 and above. So in the extremely short eyes, here again, the optical biometer again. And something to remember is that the short eyes are very unforgiving. So a very small error is going to be magnified in very off the mark IOL power. So, for instance, if a change of axial length from 20 to 19 millimeter would change the IOL power by 5 diopters. So really repeat your measurements, use the optical biometer, and the fourth generation formulae like the Barrett Universal 2, and Hoffer Q is more accurate if you're using the ultrasound biometer. So again, I talked about the IOL labeling. So in case there is a slight error also, that is going to be more magnified in these extreme eyes. And piggyback was already covered, so I'll just skip that. So yes, I think most of us are using multiple formulae, and getting reiterated what is it that we must put in these eyes. And if you have to place the IOL in the sulcus, then the effective lens position has moved forward. So here you need to adjust the calculated power, and the ranges are given in these in this table. It's very easily available. And in the silicon oil filled eyes, you need to see that the speed is going to be affected, so you have to sort of give it, there's an error if you do not modify the power. So usually the power required is 2 to 3 diopters stronger than the standard power. And I think I will just close it here. So use particularly multiple readings, multiple formulae, optical biometers, and also check what the other eye is if it is pseudophakic. Thank you so much.